and narrow scleral canal are vulnerable to thrombus formation. This anatomical risk factor, combined with altered cardiovascular hemodynamics, can be the reason behind CRPO. A variation in ventricular ejection fraction can alter pressure inside any blood vessel in our body. So our aim was to evaluate the optic nerve diameter and cardiac ejection fraction in CRPO cases. All cases with central retinal vein occlusion attending our hospital during the last 15 years, from 1997 to 2012, were included in this study. Standard protocol was followed in all cases. AV scan and echocardiography was done to assess the optic nerve diameter and ejection fraction respectively. Equal number of matched control who came for refraction was registered. Optic nerve diameter was measured with AV scans at the level of lamina tuberosa. Axial length was also measured by biometry. Echocardiac parameters were also recorded by echocardiography specialist who is unaware of the case. Ejection fraction was measured in each follow-up. Difference between lowest ejection fraction and highest ejection fraction was calculated and statistically analyzed by univariate regression. Other covariates were also recorded, like blood biochemistry. These are the pictures showing AV scan to measure the optic nerve diameter at the lamina tuberosa. This is the detailed blood supply which can be hampered due to ejection fraction. We had 82 cases of CRPO during 1997-2012. Mean age was 48.5 years. Male-female ratio was almost equal, but below 40 years age group, male predominance was significant. Now coming to the ejection fraction. Ejection fraction varied between less than 50%, which is called reduced ejection fraction, and another is above 50%, which is called preserved ejection fraction. At least 4 follow-ups over a period of 3 months in 52 cases of CRVO, which was significant in Fisher's test when compared with other CRVO cohorts. All the cases had highly significant difference with age and sex matched control. Mean variation in CRVO was 12.5%. The range was from 35% to 65%. Mean variation in the controls were 4% only. Here also it was statistically significant. We also measured mean optic nerve diameter in CRVO cases, 2.92 millimeter as compared to 3.30 millimeter in controls. And it was 3.10 millimeter in the contralateral eyes of unilateral cases of cohorts. Mean axial length in CRVO cohorts was 22.2 millimeter as compared to 23.1 millimeter of controls, which was again significant. Axial length was 0.66 millimeter shorter than their controls. So coming to the discussion, how it can cause CRVO. We all know there is no autoregulation of retinal blood flow due to high metabolic rate, and there is no autonomic nervous supply. Here lies the key. During reduced ejection fraction, heart cannot pump normally, hence less oxygenated blood goes to retina, giving rise to toxic metabolites. During preserved ejection fraction, heart muscle contract normally, but ventricle doesn't relax properly, giving rise to venous stasis at central retinal vein. This variation, maybe along with shorter optic nerve diameter, be the reason behind CRPO. These are my references. Thank you for your kindness.
Doctor, you are indirect correlation with the ejection fraction.
So the place where
the other, if you have a Doppler which can do an ejection fraction, a modification of just the probe will give you ocular Doppler studies. One. Second, when you're talking of ejection fraction, have you mentioned anything about any vegetative growth on the valves?
Yes.
There is no mention of
that. I have not mentioned that, but that was taken.
Would that be a significant
Yes,
factor?
sir. That would be give rise to honor.
You are now looking at the optic disc size. You are looking at the eyeball size. Have you looked at the size of the orbit?
Yes, sir.
Not mentioned.
Because these parameters I am doing this study for last 15 years, and with the available resources.
Basic.
I understand.
when you are looking at blood flow,
Yes, sir.
and in direct blood flow measurement is available, why do you choose an indirect one?
Direct flow measurement, we had that Doppler, one Doppler we had, we could not procure the Doppler probe for eye measurement, eye volume measurement. These things were the shortcomings of my study because it is in Jharkhand and we are in a government set of hospital. So this is my limitation. What I try to focus, it could be a clue for further studies which I can later on with the available other advanced resources we can do.
Good, Dr. Sanjay. I have to make a point.
Sir.
You mentioned that there is no auto-regulation as far as the optic nerve, vessels, retinal circulation and all is concerned. So studies, colored opera studies now have proved and it is now established that there is an auto-regulation of the blood flow because the pressure gradient across the lamina cribrosa. So mere alteration in the parameters like ejection fraction of the heart may not be the only factor that is going to determine the onset of the vein occlusion. It is more important
Regarding autoregulation, it is up to the optic nerve level. In retina, there is no autoregulation. Yes. In the retina, my question is, my study was focused on
the oxygen usually takes place at the level
and that is most of the time it is either due to toxic.
Some of the other factors causing the CRBO.
These factors were almost similar. These factors, what we found in circular pressure or other things, that were almost similar.
But I appreciate, despite limitations, you attempted this.
Thank you.
So I have a question here. You said there was a significance. What was that? Around 0.56 millimeter?
No, 2.92 and 3.8.
Yes, sir.
So,
That is unilateral cases. The other a contralateral which is not affected. That is another one.
But contralateral control comes in India.
Contralateral. We have
Contralateral of the control group you not given. You have given contralateral of the objective movement.
and
You have the slides and check it out. It's
okay, and another was the normal control. That I compared. One control is from the same contralateral eye, another is normal, those who are coming from the 40 flags.
Therefore, it is assumed that it is controlled. The fellow eye of the same patient was compared.
Yes, sir.
did you obviate the bias in these cases? Like, because it was a
Bias,
beam scan. It
yes,
was a beam
definitely.
scan. It was not a
Ultrasound was done, biometry was done by another person who is unaware of the fact. Echocardiography was done who was not any idea about the case. That way I tried to eliminate the bias.
Thank you.
Sir.
Thank you, Doctor. The next speaker is Dr. Ajay Arora. He is going to. Dr. Ajay Arora.
Good afternoon, honorable judges, dear friends. I'll be talking on clinical and lab evaluation of novel needle trocar cannula system with a proprietary metallic trocar cannula. I have no financial interest. An ideal trocar cannula should be sharp, easily available, and above all should be cheap. These are the commercially available metallic trocar cannulas today available in the market. These are the three brands which are international. This is a brand which is available within the country, but these are commercially available, ideally supposed to be single-use disposable. And this is the trocar cannula which I have devised, which basically uses a hypodermic needle which costs only ₹2 for using as a trocar cannula system. The good part about this device is this is an all-gauge device, can use 20 gauge, 23 gauge, 25 gauge, 27 gauge, and 30 gauge needle, whatever you decide, and putting in an appropriate cannula. The problem in the country at the moment is the cannula which is available. We have eventually been able to devise a stainless steel metallic cannula, but this still has some problems, but we are getting there. Now this particular device went through various stages of development over a period of 2.5 years, finally coming to this particular stage. I'm comparing all these devices with the present device where I've used with the 23 gauge needle and Alcon cannula, 23 gauge needle with Ovation cannula, 23 gauge needle of BD company with Alcon cannula, and BD company with Ovation cannula. The purpose of this study was to analyze this clinically and with penetration analysis, scanning electron microscopy, and on clinical look at the wound integrity. All the sclerotomies were carried out by doing a 5 to 30 degree biplane incision, and the sclerotomy wound was analyzed in 250 eyes with ANT and 220 eyes with alpha tropical cannula, 5 eyes with ovation, 5 with midlabs, and 5 with fixed sclerotomy clinically. Anterior segment OCT was done on 10 eyes and on ANT and alpha tropical cannula. All sclerotomies which were leaking on the table were sutured and excluded from analysis. Now we analyzed the diameter by measuring with a micrometer, which has got an accuracy of 0.001 millimeter, and you'll be surprised to know that despite what the companies claim, none of the cannulas available anywhere in the world are 0.6 millimeter. The minimum diameter for the external diameter of a cannula is 0.719 millimeter, which is for mid-labs. So all of them actually are larger than 0.6 millimeter in size. The scanning electron microscopy was done in IIT. And these are the various pictures which I'll run through. This is the scanning electron microscopy of Alcon tropical cannula. This is of the cannula of Alcon, and this is the only cannula of Alcon which has got rounded edges. All other cannulas have sharp, blunt end phase edges. This is of the mid-lab stroker. This is of the mid-lab cannula. This one is of Fitzgerald's troker, and this is a Fitzgerald cannula. This one is the ovation, which is an Indian troker, which is actually giving us a good appearance, which is non-pitted and blistered surface. And this is the cannula made by Ovation, which again has got flat edges, and they have not been able to taper the edges. This is the scanning electron microscopy of a Discovan needle. You will notice that it has got an irregular surface, but this gets obviated because all the needles available in the market are siliconized. This has got a beautiful picture of a BD needle, which gives one of the best scanning electron microscopic pictures as compared to Discovan and other tropical cannula system. We did penetration analysis on the MILAB DECA station at the laboratory of Hindustan Syringes, who manufacture about 2 million needles per day. This is the penetration analysis. These are the curves. Basically, all these curves have a P1 peak, which is the penetration peak initially of the needle or the trocar, and a P4 peak, which is the peak of the cannula. So these are the various penetration forces which are generated, and I'll run through all these slides to come to a final table which shows you in brief exactly of all the parameters for various trocar cannula systems. So when we look at the results together, we find that the BD needle has a minimal resistance, has a minimal final resistance, and is relatively good initial penetration force. The mid-lab cannula gave us a minimal initial penetration force, but had a higher final penetration force. So overall, a BD cannula, a BD needle with an Alcon cannula did better than all of them together. So on clinical characteristics, it was easy to insert subjectively mid-lab cannula. The most difficult was Fitzgerald's cannula. The Ovation trocar cannula, the problem was piece-to-piece variation because the lumen diameter was not uniform in all cases. This is a small video which you could see where the trocar cannula of ANT is being used as an oblique insertion of 530 degrees. The insertion is single step. Once we go in with a needle, we hold the cannula with, then this is another device which I've devised for fixating the globe. And once you're inside, you hold the cannula, come out with the needle, and then exactly follow the same surgical principles. The wound which we get in the end is a linear wound. 16% of the sclerotomies needed suturing with ANT, 17% needed suturing with ANT, and 16% with AT. There was no case of hypotony or leakage, and subjectively both the cannulas did pretty well. These are the anterior segment pictures.
Go ahead. Carry on. Please let him carry on.
I'll just take a minute. So these are the anterior segment OCT of with the Alcon trocar, day 1, day 7, day 30. This is the anterior segment again, or anterior segment OCT of Alcon trocar of day 1, and you can see that by day 7, most of these, this is with ANT on day 1, day 7, day 30, you can find some lamellar separation, which could be because when you are entering this, it should be fluid egress, but eventually at day 30, we are all closed. This is again a picture of ANT. You can see at day 1, day 30 is nicely closed.
This is again another picture, but here you can see a defect which is there on day 1. Eventually it heals. There's a small little blister here. This is on day 7, and by day 30 it has healed. So in conclusion, ANT 23 is a good device. It's cheap. It can be easily inserted. It compares well with the alcohol cannula system. It is environmentally friendly because we are only disposing of a single needle. It has got an all-release capability, and because it's going to cost us 2 rupees, it's going to save this country crores of rupees. I feel that ANT is a small step in making MIVs cheaply available in developing countries like ours. The day is not far when consistently good cannulas are available in India, which can work with this system and can really help us. Thank you.
Cost difference if you compare it with the available trocar cannula.
So the cost difference actually the thing is actually being marketed by Epsilon. But if you look at this, has a lifetime warranty. It never gets damaged unless until it comes out as a road roller. That's what the Epsilon is because it's made up of titanium. So they say that even if you look at the cost of 2,000 or 3,000 vitrectomies done with this, the cost of a single surgery will be less than 200 rupees. Compare it with an alcohol cannula which costs 6,600 rupees. If it is available, first of all, it is not available separately. It's available as a pack which costs 17,000. So if we get a separate cannula system like Ovation which costs about 4,500 to 6,000, and we decide that we are going to use one cannula per case, trocar cannula per case, that means we can use one system in 3 cases, then average cost will be 2,000 rupees. So if we are stringent with that, we'll be saving 10 times of the money. Most of the people...
Can that not be one? Not this one, the one which is from Alcon.
Yeah, that's what I'm saying. They ideally should not be reused. So when I'm comparing...
No, they are not for the reuse, they are disposable actually.
Yeah, so then
but if suppose we recycle them, okay, we sterilize.
So if we sterilize them, we are losing the sharpness of the needle. The sharpness of the needle is preserved if we are using every time new one. There the sharpness won't be preserved.
Do you have any electron micrography study?
Yes, sir. Scanning electron microscope.
Unused and post-sterilization.
So I have a data which I'll be presenting next time of used once, used twice, used thrice, used 4 times. Scanning electron microscopy done once, twice, thrice, 4 times. Penetration analysis done once, twice, thrice, 4 times. 6 minutes I can't include that, but I have the data with me.
Thank you.
Dr. Arora, do you think that knot leaking is mainly dependent on the way you obliquely are inserting the needle? And then insert it.
There has been a study which they have compared a 90-degree penetration versus an oblique penetration. So you go inside, turn, that is what Alcon taught us initially. Go inside, turn 190 degrees and go exactly vertically down.
So this is what you are going to do with every
Second is go 5 to 10 degrees, turn about 30 to 45 degrees and then enter. Histopathology, anterior segment OCT has shown that when you go obliquely, you're creating a larger tunnel, and this larger tunnel actually helps in closure. There is less chances of vitreous incarceration, and it helps.
Just like a self-sealing wound.
Correct.
When you go oblique.
Right.
So that is what you are going to do in all the cases.
Yes.
So leakage from the sclerotomy is mainly going to be dependent on the method of entry rather than the quality of the needle.
No, it is dependent on 2 factors. Not only that, it is dependent also on the amount of time I am going in a surgery. So there we have compared now, I have data now comparing macular surgery versus non-macular surgery. Supposing I am handling a macular surgery, which means there is a vitreomacular traction, so I want to take about 25-30 minutes and complete of the surgery. If I have a retinal detachment, which is 1 hour, then duration that won't get, despite having the cannula, that won't get disturbed.
To the normal, this trocar cannula can be threaded onto the normal your BDC to make a disposable kind of equipment.
So, if you want, should I show you one fact? Just give me a minute. But the reason why it can't be done is this. And that is the most image everything. So if you look at it carefully, this was actually, I was taking operating microscopy photographs, and one of the photographs I found there was an air bubble here. There was an air bubble here, which means that initially when I was doing, I was having a regurgitation of fluid through this. So a needle was working like a human needle. So I had to find some way of converting that into a solid structure. So what I did was, I created a small little knob. I put in a washer, which is a silicone washer. This knob goes into the hub of the needle. There's a washer here. So there is a space of air in between. This is space of air, because it cannot expand, no fluid can ever enter. So if you take a normal syringe and you go into the needle, it will always be regurgitation through the needle. Therefore, the moment you enter, the eyeball will collapse.
The results to the Chairman Scientific Committee office.
Thank you. All I can say is I wish we had a better attendance, because the quality of papers was simply superb. And a better hall with less lights. That's a technical issue.
Nuances of VR surgery. Some of these cases, and I'll invite all the panelists to be on the stage. Dr. Parveen, Dr. Chetan Rao. So we'll be taking all these vitrectomy services, and he will be starting on the vitrectomies done in patients with ARN. We'll be starting with all.
It will be interesting for you. Well, I'm going to talk about retinal detachment associated with bioimplantitis. I have no financial disclosures, and we all know about acute retinal necrosis, fulminant disease, usually seen in immunocompetent young adults. Starts as the changes that we see in the posterior segment is we see a lot of vitritis, occlusive arteriolitis, and the periphery associated necrotizing retinitis. And usually we see a retinal detachment within 3 weeks in almost 3/4 of the patients. And secondarily due to the contraction of the dense vitreous causing traction and retinal breaks in the borders of the involved and uninvolved retina. And if you don't treat the patients medically, then there's a very high chance of the progression to involve the posterior retina as well as the other eye getting involved. So the management of ARN basically involves basically we need to control the infection inflammation, which is the major problem for all the complications that you see. Restoring the media clarity, prevention of the retinal detachment, and management of its complications, which is mainly retinal detachment. We know the medical management is either intravenous antiviral therapy along with oral and topical steroids. And the role of prophylactic laser here is a little difficult to dogmatically say that it's going to help you, because a lot of studies have shown good results with prophylactic laser, but also not great results despite the laser. Because there's a lot of media opacity in the first few weeks. You can't do laser, and usually see if you do the laser, there's a possibility that retinal necrosis can progress beyond laser marks. So this is what I was going to say. And then you have large posterior retinal necrotic breaks developing, and then it's difficult to identify where's a healthy retina and a non-healthy retina. And this is some of the studies which show, one of them shows good results in preventing retinal detachment, whereas the study done by us shows an equivocal result. But still we would like to, if the media is clear enough and you can identify the areas of retina which is involved, then you go ahead with the laser. Typically you see large atrophic breaks at junction of normal and inflamed retina. There's significant traction because of the vitreous opacity, there's a retinal scarring, there's vitreous base fibrosis, and sometimes there are subtle areas of active retinitis which you cannot identify, and you see that during surgery itself. So is there a role for scleral buckling? Very unlikely, because usually in such cases, if you have to do, they have to have very good media clarity, only one single quadrant with a very small break in the periphery. So mostly it is vitrectomy you do, and generally there are large posterior breaks, a lot of vitreous opacities. There is a PVD, however you don't know where the PVD ends and the retina starts, because the retina is now atrophic, necrotic, thin, and there's a lot of PVR, and there's a continuous inflammation going on in the eye. So the goal of vitrectomy is to remove the vitreous opacity and clear the vitreous traction and the PVR. We can do a lensectomy. Very often we end up doing lensectomy because we need to do good vitreous shaving, because as I said, it leads to there's a lot of severe PVR in the later on, which causes recurrence. The role of enzyme implant is debatable. It's not very useful, may be useful in less extensive retinitis along with a good base excision. So you see the vitreous opacity that you see in the retinitis cases are almost like a dense vitreous hemorrhage that you see. Then identifying the vitreous separate from the retina is going to be difficult. You see, because this is the kind of retina you will see. All you see, I think the light is too much. That's really unfortunate. I don't know. And then, is it visible? I'm not sure. So you see this kind of retina after you clear the vitreous, and this is the retina which you need to cut, because you can't leave this retina. This most likely it's like a galactic band pulls out the retina at the posterior retina and causes a recurrent retinal detachment. And the usual tamponade of choice is going to be long-acting silicone oil, because you know there's a lot of PVR going to later on. There's an exaggerated post-op inflammatory response. You want to look at the retina, so it's best to have a long-term tamponade. And also, retinitis can still progress despite your retinal detachment, so it's important that you be able to see and treat the patient as and when complications arise. Surgical outcome is usually not very good. In AR, it's around 50%, and the functional outcome is usually quite poor because of a lot of post-inflammatory sequelae such as macular pucker, optic atrophy, ectopia due to PVR, and then you also have these long-term PVR changes like fractional detachment, persistent hypotony. So let's go to CMV retinitis, which we see not very common, but nowadays because of the awareness of HIV and treatment, we see patients coming to the clinic and being referred to us. So typically here the vitreous is very clear, usually seen in immunocompromised patient with HIV. And nowadays, because of good treatment and follow-up with the HARD treatment, we actually see them less. However, retinal detachment does occur in patients because you have gliotics, you have holes in the gliotic scar, the synergic vitreous, adding to the combination, there's a vitreous fraction also. And you can have breaks in the atrophic retina and then the retinal detachment. So the difficult part of identifying the break in CMV retinitis is that there's no contrast. There's no contrast available. You just see these dark areas. You see these dark areas, and anywhere there could be a break. And then slowly you see a retinal detachment developing. The RD may be localized or total, but the earlier you see, the better prognosis for the patient. Medical alignment, we all know, along with a good HART treatment. And demarcation laser really has no role in this case. Squirrel buckle again, as an AR, if the break is peripheral, localized, one quadrant. Vitrectomy is the choice in most cases because it's quite easy now. You can do any kind of gauge and get a good result. Identification of breaks during surgery may be possible if you look for areas of, you just take a flute close to the areas of atrophic retina and you might just be able to get something like this, a Schlieren. Which we will say that is the primary date, probably the site of the onset of RD. And then as I said in ARM, just as in ARM, we have large areas of retina which are completely gliotic, so you need to do a good retinectomy to prevent the retina from detaching. That's the posterior pole. Encephalash here again is nowadays going out of vogue, so we won't advocate that. And typically this is a good case to operate on. You have a CMV retinitis in zone 1, zone 3, quadrant, one single quadrant. You have a thick epithelial membrane also. PVD has to be induced. In this case, you won't see a PVD. And important part of PVD is that you need to get it up to the atrophic retina, because beyond that you just cannot get it. You can't get a PVD. It's usually very adherent, and you will invariably cause large breaks. So you don't have to induce PVD beyond the atrophic retina. You can actually cut off the product. Now we are lucky to see a nice break here. You have to really see a Schlieren. So this is an atrophic break, the 3 distinct break that you can see. Now PVD, You just see now. As the PVD is getting induced over the posterior core, the ERM is also going to get lifted off from the fovea. So that's the ERM, thick ERM is pulled off. Now you extend the PVD towards the periphery. And as you can see, this is a 25 gauge vitrectomy, so you can easily get away with PVD induction and all the other maneuvers that you do with the 20 gauge vitrectomy. Now, as you go to the periphery, this is the area where this is supranasal quadrant. This is the area which is involved. And if you try to induce the PVD, as you can just see, break will develop now at the edge of the atrophic and healthy retina. So, what else can you do? You can actually do a good vitreous shading in those areas which you can't, where you can't induce the PVD, and also wherever there are large breaks already present, you just make it a neat, clean break. So good retinectomy in the periphery. Basically, the intention is to free the posterior retina from the peripheral vitreous. And since it is just a single quadrant, you can get away with good vitreous-based shading also with good scleral depression. So that's what we are doing. We are shading the vitreous. And this is the eye-twitching plate that I was talking about. And then they are cauterizing it. So pre-operative, just after 3 days, the retina looked like this, and later on, the patient had a good recovery of visual acuity. So this is in a good case of one quadrant semi-retinitis peripheral zone. Long-term therapy generally would like to have long-term catheter would like to have silicone oil, and since most of the patients are already on HART therapy, I'm very unlikely that their CD4 counts should come down and have a recurrent semi-retinitis. You can actually remove the oil later on. Anatomical success in semi-retinitis is pretty good. However, functional success is dependent on zone 1 not being involved, early intervention when the retina is not fully detached, and a healthy optic nerve. Thank you.
He's again a senior consultant with vitreoretinal services and oncology services.
Good afternoon, everyone. I'll be sharing about foreign bodies and with a case-based approach. So eliciting a thorough history and virtually reconstructing the setting of trauma, a thorough examination and appropriate imaging goes a long way in planning a management towards such eye. So the patient should be explained that the surgical procedures could be staged, concomitant traumatic sequelae. It's worthwhile speaking to the patient about counseling him about the prognosis, the anatomical and visual prognosis, so that he has realistic expectations from the situation. Tetanus prophylaxis should be provided where appropriate, and polycarbonate glasses should be advocated. So this slide shows that there is a foreign body in the protective requirement. You can make out arteriolar occlusion beyond this, so in that way it's really unusual. Imaging, ultrasound, CT scan and UVM in certain cases can pick up foreign bodies. So the situation also depends upon what type of foreign body we are dealing with. It could be metallic or non-metallic. The metallic could be magnetic or non-magnetic. Non-metallic could be glass, plastic, organic, or distributed IOLs and CGRs. So going back to the magnetic foreign body, which you first saw, this video shows this is from the 20 gauge era, and good vitrectomy is done, the PVD is being induced. So the traditional teaching is with foreign bodies, do a good vitrectomy, induce PVD, complete the vitrectomy, approach the foreign body, cut the capsule, relieve the foreign body, do a retinopexy, use an endotamponade where necessary. So here the foreign body is dislodged from this area of impact. and with a handshake technique pass the foreign body from one hand, non-dominant hand to the dominant hand. So there's another case of silver intraocular foreign body. This is a person who's working in a silversmith shop, and the foreign body was in the ocular cords. CT scan helps us differentiate or accurately localize the relationship between the foreign body and the cords of the eye. There's a dense reaction and dense hemorrhage. So the surrounding regions are relieved. The retinal breaks cause cauterized. The foreign body is released from its adhesions. Sometimes this can be really thick, and you can see it's a flat, curved foreign body. Though there is one challenge in isolating or freeing this foreign body. It's another challenge to remove it from the eye. So this is again from a 20 gauge approach, handshake technique. It's delivered through the limbus. So we saw enlarged sclerotomy and delivery, limbal based delivery of the foreign body. So this is another case. Lensectomy is being done, anterior capsule is preserved, vitrectomy is proceeded with, vitreous hemorrhage is cleared. And now the PVD is being induced. So these all steps are really important in giving the long-term stability to such eyes. The area of impact of the foreign body is now explored. The size of the foreign body was much larger than the area of the break scene, so retinopexy was done before. And then when we tried to graze it with an MVR, it was far more embedded than apparent. So an external approach was made, and with the scleral cut down, the foreign body was removed much more atraumatically than through the intraocular route. So this case shows that you should be open to other alternative strategies during the surgery. So the foreign body is out, the sclerotomy is sutured back, and then you go back again, inspect the fundus, and use the endotymphoid. So in the end, since we had preserved the capsule, the macula was good, we implanted an intraocular lens. So this is a 25 gauge approach to a similar situation. You can see the area of entry in the cornea. This is the area of entry in the lens capsule. So capsular access, including the area of impact or rupture in the anterior capsule, is done so that there is no anterior capsular tear using the lens aspiration. So the rex is now extended to include that area of the capsular tear. And then the other thing that we should be careful about is no hydrodissection in the presence of a pre-existing PC defect. So the lens is aspirated and we can make out the PC defect here. And vitrectomy is done, the foreign body is freed from its position of impact, and it's delivered through the PC lens and from the cataract mode. So liberal cover of viscoelastic is really advisable. trauma, this approach would be useful in providing a good visual recap in the same thing. So there's another video of a glass horn body, which are really difficult to hold and deliver out of the eye. You can see a large corneal tear that has been repaired, and this foreign body is being removed. These are really challenging cases, and the prognosis is really, really guarded. So the last video of caterpillar here. It's being removed from the episclera and also from within the eye. There you can see a lot of intraocular cilia being removed. Thank you very much.
Thank you, Dr. Parveen Singh from Shankanetralaya will be talking about
organizers for giving me a chance to speak here. We are here talking about the nuances of vitreoretinal surgery, so I would feel that retinopathy of prematurity in itself forms a real different entity, because a lot of our principles which we usually use for VR surgery may not apply when we do a surgery for retinopathy of prematurity. We may think it is more like diabetic retinopathy or diabetic vitrectomy. It doesn't behave like one. We may think it is like extensive PVR. It doesn't behave like one. So probably it is the last deathbed for most of us, and we have to give it our best and try to do the best we can under very difficult circumstances. To just, I have no financial disclosures, and to just introduce the topic to you, prevalence levels really increasing in the third world countries because of increased survival rates and still a poor ROP screening protocol in place. And we have, in many of the instruction courses today and day before, seen a lot of talk on the pathogenesis, so I will skip that as well. And where stages 1, 2, 3 are concerned, they are primarily managed by something which is very effective, that is laser photocoagulation. Even patients with plus disease do respond well to laser photocoagulation, and good response to therapy is seen, as we see in most of these cases here that I have to show. There are few particular scenarios where definitely the laser may not be effective, and one of them which first comes to my mind is AP ROP, and as well as the zone 1 ROP. Both of these entities may behave in a very different way as compared to the typical stage 3 plus disease. And here is where we may need to resort to surgical procedures very early on. This is one of the few examples where even in zone 1, timely laser has been able to achieve regulation of disease, but not all babies, not all eyes are so fortunate, and we do see this kind of picture here. So here, though I feel the visualization may not be so great, but enough for you to pick up that here you are beginning to have a retinal fold which is in the periphery. The central macular area is still not involved, and here you see that faintly the disc is here and the fold is reaching up to the disc. So this is the 4A which is not involved in the macula. This is the 4P where the macula is also involved. Both of these stage 4 and stage 5B are primarily concave tractional detachments, and there is no vertiginous component, we believe, at least to begin with. So to begin with, you will have a concave configuration of the RD. And here this is an end stage, that is the stage 5, where the whole retina actually lies right behind the lens, and the rest of the retina is stretched into a deep funnel up to the optic disc. So the retina is actually blowing up like this, flattening out here behind the lens, forming a peripheral loop, because this area of avascular retina usually does not show detachment, remains attached, and the vascular retina shows detachment, and it forms a peripheral loop. This is something which I will speak subsequently about. That you need to free this space and get into this space, then only this retina will fall back here. Preoperative analysis to understand whether the plus disease is still active, because if so, you may lose the eye before even you start your surgery. It may bleed extensively. So if you recognize that the child has plus disease, has rubiosis, has chance of vascularity, best is in this present scenario to go with a pre-op injection of anti-VEGF. And in stage 5, you look for signs like small pupil, corneal opacity, flat chamber. From my experience, I feel all these usually point towards a pre-existing regma. That means already because of extensive traction. First we had a traction lardy, which because of the pull has caused a break somewhere, and regmatogenous detachment has already set in. If that has happened, then surgery will usually be futile. Preoperative analysis using ultrasound may also be useful. You may see presence of the crystals or subretinal precipitates, or in some cases the peripheral loop can be picked up. So presence of the loop again means usually that regmatogenous component is not there. Presence of subretinal precipitates usually means it's a long-standing detachment, where even if it's a tractional detachment, it will be difficult to set. So first, traditionally what we used to do early on is scleral buckle, and scleral buckle in a given class of defined cases of ROP still holds good. This has to be typically a stage 4A disease where the macula is not involved. Even if peripheral fibrosis is there, that should not be a contraindication, because you don't always need to relieve every bit of fibrosis, and even if you try with LSV or lens, you may not be able to relieve the traction always. Here, this scleral buckling here, or belt buckle, as we normally say, is not very much different from what we normally do. We do make these tunnels, and after tagging the muscle, and I think again there's some problem with the video, it's got stuck. Anyway, after the tunnels are made, only important thing where it differs from the rest of the belt buckle is that the height of buckling, the place where you want to put a belt buckle is decided upon by indirect ophthalmoscopy. If it coordinates with the height of your detachment, that is where if you put your belt buckle there, it will be of maximum advantage. However, it definitely cannot be done for TRDs which are involving the macula, and it necessitates removal at 1 year of age because of the growth of the eyeball. It can erode into the eye. Most commonly done surgery these days for ROP is the lens perimvitrectomy. Here you see that it is usually done in macro TRDs, and here I am fixing a combination instrument actually, which has a combination of light pipe as well as infusion. This instrument comes from Synergetics, and it is pretty useful because once you have this in place, it allows you bimanual dissection, which you usually need to do in most of your cases. We prefer to do a small gauge surgery in ROP, and here I'm using a 25 gauge, but you can see the eyeball is so small that there is no room to rotate it. So actually I have to come out with the trocar and gone in directly. The reason also being that more often than not we always do suture these sclerotomies because the scleral rigidity is so low. So once you are in, you can see these membranes are there. They're very nicely seen, and these pegs can be identified sometimes. You can hold with the forceps of one hand, scissors on the other hand, go in between, and you can cut. You may not always be very lucky to see these kind of pegs, but I hope you can appreciate that the whole of the retina is absolutely elevated. It is almost like a stage 5, but then since peripheral, some amount of laser has been done, I have some working space where I can do the surgery without removing the lens. Here I am freeing the peripheral area of the retinal adhesions, and again coming back to the central product, you see there is no plane of dissection. That's why I said it differs from your diabetic vitrectomy. Whatever you do, you don't find a dissection, and you just have to force your way through. and bleeds in the end, even though it was supposed to be vascular surgery. But once this is gone, the fibrous tissue, you see the funnel has now opened up. This area is opened up now. And that is our goal of surgery. We do not aim to reattach the retina on the table. The aim is to just relieve as much of traction as possible and just leave the rest for the tractional forces to work on. Posterior, as I said, we cannot induce PVD and whatever, as much as possible you have to remove the traction and leave it at that. Post-operatively, you may have some bleeding, but you don't need to go in all the time unless you see that this non-clearing hemorrhage or your retinal detachment is worsening. Complications like lens touch can always happen because it's a small eye. You may fail to reattach the retina because the traction relief may not be enough, or you may have formed a retinal break, in which case further intervention may not help. Advantages is that the lens is still preserved, so it helps early visual rehabilitation, and unlike scleral buckling, you can tackle a posterior RD as well as there is no need for a subsequent removal. Our results have been nearly 75% success rate where LSV is concerned, and we are close to what Tracy et al. Have reported, up to 90%. Coming to VR surgery for stage 5, this is, as I said, it is stage 5, so needs lensectomy as well as vitrectomy. Since we are anyway going to do away with the lens, I prefer to make corneal entries for my dissection because it further reduces the chances of dialysis and nitrogenic problems, because here the retina is all pulled up very much anteriorly. Lensectomy is very much like any other case, however, only one thing, that you need to keep a very low flow and a very low vacuum, because sudden collapse of chamber is possible, and sometimes the sudden collapse is enough to cause a peripheral break and you lose the case before you've started. Following this, we have the retrodental tissue which presents to us, and the sharpest instrument probably is a 27 or 30 gauge needle that you can use. Using that, you can make this cruciate shaped incision across like this and here, and you have to work your way through. I prefer to clear up the infratemporal quadrant first, and then I fix in my maintainer to facilitate intraocular pressure maintenance, because once the maintainer is fixed, then you cannot dissect on this end. This is followed by removal of the retrodental tissue all around. And once that is done, you see this is the folded retina lying behind, and if you can appreciate, that's the fold of retina, and that in the periphery is the loop, which I was talking to you earlier. So it's the peripheral vascular retina which is still attached, and then there's a fold here of avascular retina which is detached, and once you open up this loop, the traction really gets relieved and the retina falls down. So once you've taken care of the peripheral loop, now comes in the central area where we proceed with the dissection as before. Once we have cleared all the cruciate incision and all retrodental tissue has been removed, now we have to dissect deep into the funnel and go down and open the tissue which goes up to the disc. That is precisely what is being done here. Again, I apologize for the quality of the video. It really is quite sorry, but if you can appreciate, once the dissection is done from the periphery, this tissue is picked up and almost forcefully dissected here. You almost have to stretch it away, and then finally I lift it up from the disc. While you're lifting it up from the disc, you will have some bleeding. At that time, you need to remember that immediately you should not come out, and allow things to settle down, the bleeders to settle down a little before you come out, and then the elevated spots can be cauterized. Here you see this is the last bit which is coming out from the disc, and as that happens, you have some hemorrhage, which is that subsequently bleeders are cauterized. This is another scenario which now I feel more and more of us will have to handle, that we are doing laser, the ROP does get regressed, but these children sometimes at the age of 5 or 6 develop a rheumatogenic detachment with the regma happening at the edge of the laser photocoagulation and the normal retina. Here the remnants of the fibrodental tissue may still be there present on the retina, and very thick and very fleshy vitreous is there, so you cannot pull it up. You see the vitreous here is being removed like a sheet, and I'm doing a bimanual dissection to remove the vitreous with a chandelier in place, and still it comes off piecemeal, and once that happens, you can then follow it up with HGE and endolaser. This is another case of retinal detachment in a regressed ROP. You see, it's sieve-like, it's full of retinal breaks where each previous laser photocoagulation mark has given rise to sieve-like retina. Usually macular holes are always present, and there is some remnant of neovascular tissue still present. You can see that here. And this area is totally contracted, and it's impossible to really release traction over there, and that area has been cut. So even in these cases where seemingly before you have an attached retina, the retinal detachment happens subsequently, the high rate of failure of primary surgery has been even seen by many other surgeons as well, up to 25 to 50%. My topic may not be complete if I do not mention the role of anti-VEGF in ROP at this stage. Just to go through it in a couple of slides, that it is the driving force in ROP as well. As was seen in the ROP study, they have used it instead of laser, but here we are using it most often than not as a rescue therapy or before a difficult surgical intervention as an adjunct to vitrectomy. So in conclusion, majority of cases can be prevented from going into stage of retinal detachment, and if that happens, LSP or still buckling, the results are still good, but with stage 5 the results are very unsatisfactory, and bevacizumab can be a useful adjunct to surgery. Thank you for your attention.